Good morning, good afternoon, and good evening, everyone. And thank you so much for joining today's ACNS YNS Webinar. And it's a happy day to see many familiar faces all together. And so on behalf of the Educational Committee of ACNS and Professor Kato, I would like to start today's ACNS Webinar. Today, our chair is Professor Salman Sharif, who is the chairman of the FNS Spine Committee and the past president of World Spinal Column Society. He's also the chief of neurosurgery of the National Hospital and Medical College in Karachi in Pakistan. So our speakers today, our first speaker is Professor Yoon-Sung Kim, Harrison Kim, who will be talking about the evolution in endoscopic spinal surgery as minimal invasive option in patients with degenerative spines. Second speaker is Dr. Sai-Kayan, who will talk about the accuracy of pedicle screw placement using O-arm navigations. And our third speaker is from China, Professor Chen Xiaorui, who will be talking about the topic of from virtual reality to mixed reality, the development of a low-cost neurosurgical planning and training system. For our discussion today, we have Professor Ølvig, who is the chief of the Neurosurgical Center of the Clinical Hospital of India, and also the president of Canadian Association of Neurosurgeons. And also Professor Prasad, who is the professor of Kabul University of Medical Sciences and the chief of neurosurgery department of 𝐸𝙧𝒏𝙉 University Hospital. He's also the president of the Afghanistan Neurosurgical Society. To moderate the session with me, we have Dr. Sajin, Dr. Atik, and also Zhou Sam, and also Dr. Sukiti. And so without further delay, shall I invite our chair, Professor Salman, to introduce our first speaker. Professor Salman, please.
Yeah, I'm grateful. And I think Kim does not need any introduction. As we know, he's been all over the place teaching, training, and helping in minimally invasive surgery. Endoscopy is his passion. What he's done in last few years, I think nobody else was able to achieve. I think if you look at that from that aspect, his Harrison Hospital is taken up big time. He's got 2 units now working for him, and he's got loads of young neurosurgeons from all over the place going and learning, then going away and teaching. And I think it's wonderful. I think for us to listen to his talk regarding evolution, it's brilliant, and I'm grateful, Kim, for coming here. So, Kim, off you go.
Thank you so much, Professor Salman Sharif. Can I share my slide first?
Yes, please.
Please.
Okay. Can you see my slide?
Yes. Please make it to the presentation mode.
Okay. Can you see my slide?
Yes.
Okay. Thank you so much, Professor Yoko Kato and Professor Salman Sharif. It is my great honor to give a talk in ACNS Young Neurosurgeon lecture. I'm Hyun-Sung Harrison Kim from South Korea. This time my lecture topic will be evolution in endoscopic spine surgery as a minimal invasive option in patients with degenerative spine. Actually, as a neurosurgeon, I believe that this issue will be very important in the future for the patient for healthy. Yes, we already well known that with the increase of the people's midlife increase, so abruptly increases, so rapidly increases people's midlife. Because of that, before time we only focus on the disc pathology and also some very serious cases of degenerative disease. But nowadays the lumbar-spinal stenosis and so serious problem increase with so much, and that also will be in the future the social problem as a medical part. Because of that, to solving this problem will be very, very important as a neurosurgeon. As fortunately, endoscopic spine surgery during last time developed so much, and also the generation of endoscopic spine surgery from discectomy generation nowadays going to decompression and fusion generation. Because of that, and also with the development of the instrument, with the development of the technique, nowadays we can near all types of degenerative spine disease can managed by the endoscopic procedures, and also scientific basis give the more time to good result compared to the open surgery. And we know that as a rationale of the endoscopic spine surgery, firstly, we can find as a transfemoral approach. You can see here, this is very serious cases of lumbar disc herniation, hope to make like this finally. But this is very important to preserve not only solving the disc pathology, but also preserving the very important functional structures to preserving is our goal to as a minimal invasive neurosurgeon and endoscopic spine surgeon. And for a purpose of these procedures as a endoscopic discectomy of the transfemoral approach, firstly starting from the visualized approach from Tony Young 2000, then is processing the visualizing approach for extradiscal for by Thomas Sugland in 2005. But this process is going on so long time, and the first time we this endoscopic spine surgery only focus on the disc pathology. But with the 2008 maybe 18, I introducing the mobile outside-in technique, and nowadays all types of disc lumbar pathology can approach from the transfemoral approach above the L4-5 level. And also, you can see like this case is a very serious case, is a very, very high inferior myography, very, very superior myography cases before time is a very complete contraindication of lumbar disc endoscopic approach. But with the development of like suprapedicular circumferential opening technique introduced by me, and transpedicular approach introduced by Kuntram, now this problem solved very easily like this way. It means that is very important before time lumbar disc pathology, as I mentioned, very important serious pathology, but nowadays this is not serious pathology. After solving this problem, the patient can return to their normal life. For example, like this highly superior myography, you can see the transpedicular approach, then this pathology can solve completely. And also this case is my case is of only 15-year posterior posterior apophyseal ring fracture cases. Like this case is also not easy before it sometimes in the fusion surgery, but if we can solve like these cases by the endoscopic like this way, the patient, in spite of the only 15 years young man, that can save his spine as long for his life. And also, a recent study talking that this like the very disaster 𝑺𝙤𝑒 cases or nerve damage cases using the endoscopic approach can give the more minimized retraction that give the more chance to recovery to like this disaster cases. This patient also recovered his 𝑺𝙤𝑒 completely. And also another advantage of the endoscope procedures, this I believe that the dural repair is very easy in the endoscope procedures. In the endoscope discectomy and endoscope decompression, we met so many cases dural tear, but it very easily taco shear application can solve that problem. Because of that, usually not happen so serious problem. And also, like this way, the discectomy is still not solved completely. It needs some more like L5-S1. To solving this problem, so many doctors try the L5-S1 transfemoral approach. But intramural approach came from long time ago, and I like that this intramural approach can with the structural preservation that's similar to the transfemoral approach. Because of that, you can see here the structural preservation, meaning that ligament problem splitting and annular sealing make a near completely preserving the structures around the functional segmental area, and after that you can see the disc pathology solved near completely. And also 2014 first introducing the contralateral approach of the intramural approach. Then this is very important because of that. After that, we believe that it can possible endoscope decompression to the contralateral. We think like at the time, and also we tried so many cases of contralateral foraminal pathology approach using this way. And anyway, using this development of the endoscopic spine surgery, this paper I published in maybe 2018. At this time also, recently, we believe that the lumbar disc pathology very easily solved by the endoscope procedures, and the all types of the lumbar disc pathology solved by the endoscopically, and then take more than 95% clinical exam can take this way. Because of that, nowadays we think like that, and more focused on the endoscopic decompression and endoscope fusion surgery. Because of that, there's more many cases we met, and more serious to solving that problem. And anyway, first time we think about it, what is the advantage of the endoscope decompression compared to the open or minimized spine surgery. But you can see here the real advantage will be this very mobile and angled and more deeper and more clear view we can take during the procedures. Because of that, we can save the more functional segment, and we can manage the more deeper, more difficult point of pathology. And actually, endoscope decompression first paper interesting 2007, Dr. Reuter, but actually starting of the endoscopic over the top technique. Nowadays, many doctors using this over the top technique. Maybe first in starting maybe these two paper published by me 2018 and 16 maybe. This over the top technique and this contralateral approach for foraminal pathology, and after then nowadays we can see like this way of the in serious spinal stenosis cases we can save the near all facet and all muscle and all ligament or structure to function as stability. That is another point of tensegrity, and also using this then also developing the contralateral and terminal approach for contralateral foraminal pathology. For example, this case is before time very disaster cases then need of the multi-level fusion surgery. But if we can solve by the endoscopically only pathology point decompression like this way, contralateral approach foraminotomy, the patient will take a more good clinical result. And I followed this patient more than 5 years. The patient still have no pain. And a recent study showing the more good clinical result compared to the open surgery. For example, this paper published by me talking that some more facet joint preservation is more completed to the open surgery. About more than 90% facet joint can preserve using this process. And you can see here the pre and post-operative, in spite of a complete decompression, the facet preserve near completely. This is a very key point of the stability of the tensegrity. And also, recently another study published by me talking that this can preserve the paraspinal muscle completely. Because of that, there is a more good to the patient stability preservation. And also, another study of the published by me talking that in spite of the so old geriatric patient, this patient, 80-year, very serious spinal cases, can solve the more safely using the endoscopic spinal procedure. That will be very important in the future because of that. Especially in Korea and Japan, we already met more than the patient need more than 80 and sometimes 90 years. All the patients that need a decompression, sometimes fusion surgery that. And post-op, I like here this Karachi, Pakistan, in ACNS educational course. I love here. And also with the development of this endoscopic decompression of the lumbar over the top outsiding technique, that will be very, very important to processing the thoracic decompression and cervical decompression. You can see this paper published by me 2022 operative neurosurgery. They are still talking that over the top technique can more safe like this spinal osteopathic occupied the rhythm of the problem spinal stenosis cases like this. And also you can see these cases maybe preoperatively with the nerve damage rather than sufficient decompression by the patient walking, and only 3 days the patient motor recovered more sufficiently, and after 6 months part of the patient motor recovered completely. Because of that, developing the endoscope decompression of the outside will be very, very important function in the future. And also using this outsiding over the top technique, nowadays we can apply the cervical procedures. Cervical have two procedures of posterior approach. One is a posterior foraminotomy and one another is a posterior decompression. You can see these posterior foraminotomy cases, and also foraminotomy first before time only, foraminal decompression only. But nowadays with the partial pericrotomy, partial vertebrotomy, published by me, you can see here the technique partial pericrotomy, partial vertebrotomy, then more widely accepted, more safely accepted to the ventral area. Because of that, like this serious cases, stenosis can easily solve like this way. This also very important procedures of the endoscope, cervical procedures. Recently, there are cervical procedures my clinic doing these procedures. And because of that, you can see like this decompression, and you can see this sufficient decompression. And also facet joint preservation also, in spite of the endoscope procedures, usually save the skin and muscle. Because of that, in spite of more than 50% of facet damage is not in aggravation and stability. That is a very important portion. More we can take a sufficient decompression of foramen like this way, then the patient can take a more clinical result, and still the patient return to normal life more chance. And also this application of the posterior over the top technique can take application of the cervical decompression like this way. You can see the single level decompression is possible, but nowadays 2-level and 3-level decompression also can possible of the uniportal and biportal surgery. Or you can see this patient came to my clinic with quadriplegic paralysis with you can see severe stenosis C3-4 and C4-5, C5, C6-7, and also endoscope decompression. You can see here all decompression 4-level, and you can see the all decompression by the endoscopically is done sufficiently, and the post-op PMR you can see here, and the patient motor recovered so much, and the patient discharged with the working state. Because of that, but still this cervical decompression is some ongoing state, not finished completely. But I believe that endoscopic cervical decompression and thoracic decompression finishing that near all degenerative spinals can more safely treated by the endoscopically. And also nowadays we're going to the endoscope fusion generation. This endoscope fusion, we believe that I'm starting endoscopy spine surgery more than 20 years, and I believe that that is not possible in my generation. But it processing so rapidly, maybe. And nowadays, they are all degenerative diseases that need a fusion surgery can pass over by the endoscopically with unipolar and bipolar all together. And also endoscope fusion approach can divide it by trans and posterior, and this mixed posterior approach. I use this posterior approach. And that has this transcambient approach and posterior approach has this their own advantage and disadvantage, but I like this posterior approach. This more the all can application is possible, and using this Kim's point, we can resect SAP and IAP more rapidly because of the operation time is not long and the general anesthesia is not needed. And also, developing of the endoscopy postlateral approach may be needed some instrument and technique and clinical results. Here we can see I introduced the Harrison cage glider that easily, safely delivered the cage into the target point, and introducing the Kim's point to the belly easily resection of IAP, but maybe that need less than 10 minutes for resect to whole SAP and IAP. And also recent clinical results showing that more good fusion rate compared to the open surgery. That is a basement of the endoscope fusion surgery processing. And also the real tips of the endoscopic lumbar interval fusion. Here you can see these two. One is a chronic adhesive disc drilling, and one another is endoplated denudation. This chronic adhesive disc drilling give the very good restoration of the spinal alignment, I will show. And the endoplated denudation give the more good clinical fusion, more good fusion rate and substance, more less substance rate. And you can see because of that, this distinctive advantage of the endoscope fusion surgery compared to open surgery will be like this. You can see using the chronic adhesive disc drilling and endoplated denudation, you can take sufficient segmental correction like this, and sufficient restoration of this height and sufficient restoration of spondylolisthesis can easily possible using endoscope procedures. You can see that this case is L5S so collapsed because of that. That is not easy restoration, and that is not easy give the 16-degree cage, and that is not easy a large cage. But using the endoscope procedures, you can see like this is possible. And also this another similar cases of so serious with cases, and also can by easily inserted large cage and a large angle, large height cage is possible using the endoscope procedures. And also recent this study paper published by me talking that endoscopy interval fusion using the endoplated denudation can give the more good fusion rate. You can see this L5S cases also 3-year follow take a complete fusion. Right, and also this paper talking that more good fusion rate compared to the open today. And also recently my paper talking that in spite of that, this kind of restoration is very nice, and segmental correction also very nice. Because of that, it can possible indirect decompression is possible. Because of that, you can see the contralateral frame is indirect decompression is possible. Because of that, like very serious cases, only serious cases need decompression, but usually that needs not central decompression is not needed in the endoscopic posterior decompression and fusion. And also this is a posterior post-op scar of the endoscope fusion, but this is also a very important portion. Because of that, I will show some cases of the spontaneous restoration of spinal alignment, but I believe that the restoration is a basement of the tensegrity of the preservation of the skin, preservation of the supraspinous neurons, preservation of all structures muscle that give the more to chance to the restoration of spontaneous spinal alignment restoration. I will show final cases by some cases. You can see this very severe collapse in the L5S1 cases. Before time, this is not easy in the open fusion cases, but using the endoscope procedures, this restoration is very easy, and you can see this very excellent clinical result. And also, in spite of the 85-year-old male patient, like this severe collapse patient, it is very easily restoration because of that. It is not need a general anesthesia, only epidural anesthesia can possible. And also operation time is less than 2 hours skin to skin because of that is possible. And also like this disaster of the pelvic surgery case is very usually some restoration of the like this way using the endoscope procedures, and the patient to take a very serious clinical result in spite of a 1 year, 3 year follow. And also, I showed that this case before. This patient received it before another clinic, and you can see the spondylolisthesis, rectus, and so this is cases of complication. But if we can take a restoration like this way, in spite of the large angle is possible and the restoration is possible, the patient will take a very excellent clinical result, can possible chance to take a return to their normal life. And also, this another very serious case is degenerative kyphosis. And also, I believe that before time, that is not possible by the endoscopically, but I believe that nowadays it is possible. Scoliosis cases already, I published the paper, but kyphosis, I believe that that is possible in the future endoscope procedures like this way of the spontaneous tensibility of the restoration. And this another case is, and I will show final cases. This case is also, you can see the spontaneous restoration of spinal alignment with the following endoscopic with the tensibility. But nowadays we try the new trial of the chronic back pain, discogenic pain cases with the vegetative neuropathy. I hope you like read this paper of my paper, because I have no time. I will pass. You can see here some. They have the characteristics, three character of the adhesion, neovascularization, fat infiltration, and with this ovulation, you can see this very serious case of pain and body change will disappear 1 year, and 4 year disappear completely. The patient have no pain without no fusion surgery. Without fusion surgery. Yeah, in conclusion, this slide showing that I opened my hospital maybe 8 months ago, and we already achieved 1,000 cases of surgery, and among them only 3 cases of the open surgery, and another all cases of the endoscopy, and 4% of the minimal invasive spine surgery, vertebroplasty, and like others. It means that all cases of degenerative spinal disease nowadays can possible endoscopic procedures, and with this development, you can see here there's an endoscope fusion only about 10 or 12% of in my clinic, less than 15%. It means that very important to decreasing the fusion rate and more good clinical result to the patients. And now that we can possible to give the no open surgery, no shoot after operation, no dressing after operation, no transfusion during operation, no general anesthesia for lumbar, and minimizing the infection after operation is possible using the endoscope procedures. This image is showing the last year government in South Africa, and this endoscopy session. So many doctors nowadays interested in the endoscopic spinal surgery, and I believe that always there is nothing in the world that does not change. I believe that we, as an endoscopic spine surgeon, as a neurosurgeon, I believe that we will good clinical result to the patient. Thank you for your kind attention.
Thank you so much, Professor Kim. So shall I invite comments from Chair Professor Sharman?
Yeah, I think as always, I think what Kim is showing that obviously new technology is taking over. To challenge that, I think some of my colleagues who are old-fashioned neurosurgeons say that obviously the new technology is taking over because what they were doing initially was not correct, and that's why they have to continue to evolve and improve. Whatever it is, obviously, if it's for betterment of the patients, I think it is brilliant. More and more people are doing that, but I'm sure this is not the end. I think there'll be a long way to it, and there'll be new things coming up. And I think it's a brilliant lecture by Kim, as always.
Thank you so much.
So can I ask a question, Professor Kim? So first of all, thank you for your support for the ACNS activities, and also thank you for the very comprehensive lectures. So as a young neurosurgeon, so we all are interested in this new technology about the endoscopic spinal surgery. So I want to ask, first of all, in your daily practice, so would you use navigation in your daily practice, and what are the pitfalls in using the navigations, in your opinion? So another question is about since that now there are so many options or disease condition that you can deal with the endoscope. So what do you see the future development of the endoscopic spinal surgery, and what are the future challenges?
Yeah, thank you so much, Dr. Ben. But unfortunately, I'm not used the navigation. But I'm many times talking. There are two reasons. One is that I am not rich man. That's not important. But another point is more important. But still, I'm always talking that the navigation have a developing 2 points. 1 point is a doctor's point. 1 point is patient point. But nowadays, only going on the doctor's point. Because of that, the expert surgery usually that is not needed. It means that nowadays only pedicle screen navigation. But I believe that in the future, patient-based navigation and system will developing. That time, I will try the endoscope. And also, I believe that developing based on the endoscope procedures, because of that, that time I will starting the navigation. But unfortunately, I still have no prepared that. And also, your second question is so many conditions and degenerative disease came to my clinic, but the surgical procedure protocol standardization and all procedures with the standardization same all degenerative spinal disease can possible. Only I already talking that more than 1,000 cases of degenerative spinal disease came to my clinic, and only 3 open surgery. 3 open surgery all myelopathic cervical disc and serous patient. Because of that, another all cases is possible by the endoscopically. Only very limited cases is needed still open surgery. But I believe that in the future they also will solve that.
I see. So thank you so much for your question. I just as a last comment is last question about in low income country, do you think the endoscopic style surgery, since is proved to be has an advantage in operative time, decrease radiation exposure, and also a decrease in the blood loss, do you think this technology can be promoted to low-income country in the future, and what are the challenges that you think we need to overcome in order to do that?
Because of that, I like biportal endoscopic spine surgery. I'm only doing the still uniportal endoscopic spine surgery. I believe that in the future, uniportal and biportal will go together, and they're developing some differently and join together, but there are different advantage and disadvantage. I believe that scientifically, the mostly starting from the came from the uniportal, but the as a comment, use some economically and some teaching point, the bipolar spine surgery is spreading more widely, and that there was a more good chance to low-income country to developing endoscopic spine surgery. But we should know, in spite of the starting the bipolar spine surgery, we always talking that what is the advantage in unipolar and bipolar. That is not important. More important things is that how we can serve the more good clinical treatment to the patient. That is more important, not the important in unipolar and bipolar.
Yes. Thank you so much. And congratulations to your result and your hospital. Thank you so much.
Thank you so much.
Professor Kato, you want to say something? Please unmute.
No, it's okay. Thanks so much, Dr. Kim. So especially the scoliosis case is very, very interesting for me, I think, with minimal invasive treatment. Great results. Thank you so much.
Thank you so much, Professor.
So, are there any questions from the floor? So, maybe, Dr. 𝐸𝑒𝑒𝑘𝑒𝑟𝒔, so I know that you also do focus on spinal surgery. So what is your opinion or any comments to Professor Kim's lecture?
First of all, it was a wonderful presentation as usual by Professor Kim, and what all the minimal endoscopic work which we are doing, and we have learned it from him. And of course, the availability, the opportunity, the learning curve plays an important and major role. And selection of the cases initially, as a beginner, the selection of cases is very important. That's what I think. And there is a long way to go.
In my opinion, the educational process is really very important in the future. Before time, many doctors hope to learn the endoscopic spine surgery, but actually they have no training course and educational course in the college program. But if doctors learn using the educational program, in spite of that they do not endoscope pressures during the resident or some other time, they will more easily starting and more easily overcome their learning curve. I believe I saw so many my fellows, they starting very easily in spite of I'm not gave the operation finally. They all learn some midpoint, but they doing all process very easily.
So do you think it's necessary for the young neurosurgeon to master the open surgery techniques before they switch to an endoscopic technique? This just like just taking the analogy from the endoscopic spine transsphenoidal surgery. So in the old days, they need to switch from microscopic to endoscopic. So the same in the development of the endoscopic spinal surgery. Do you think it's necessary?
Yeah, and that is a basic. That is very important to learn open surgery. There are 3 points. One point is that some maybe sometimes there have some indication of open surgery that need some that times that need some open surgery they need. And second point, during the procedures, endoscopic procedures, especially young surgeon will meet many cases of complication that need solving by the open surgery. But and also with the collaboration of the Third is more important is that some to learn the open surgery anatomy completely more easily accept to the endoscopy. Because of that, the learn open surgery is basic, not necessary. That is basic.
Yes. Thank you so much. So, are there any comments from the forum? So, if not, shall I invite our chair, Professor Suman, to begin the next section?
Brilliant. I think we have the YNS speaker, and we have 𝐿𝙬𝙙𝙀, who's from Hyderabad, India, who's obviously one of the many people who have done fellowship with Professor Kato. And it's brilliant to see him here. And he's going to be talking about accuracy of pedicle screw placement using the O-arm. Let's see what you have for us.
Ben, can I share the screen?
Yes, yes, please go ahead.
Is it visible, Ben?
Not yet. Let's see. We try again now.
I'm unable to share here, Ben.
Any problem with the share button is at the green button at the bottom of the screen.
I'm unable to.
Are you clicking on the share button?
Yes, sir. I'm clicking. I'm very much clicking on it, but
maybe what you could do is maybe you could go out of the Zoom and then come back in. That may help. Oh, we have got it here.
Is it okay, sir?
Yep.
Yeah.
Yes. Is it visible, sir?
Yes.
Yeah. First of all, I would like to thank my mentor, Professor Yoko Kato, for giving me this opportunity to present my work in this platform. And I'm fortunate enough to present this in front of legendary surgeons like Professor Salman Sharif, Professor Kim, and Professor Chin. Very good afternoon, everyone. I'm going to talk about the accuracy of pedicle screw placement using the O-arm navigation. Myself, I'm Dr. Sai Kalyan. I've completed my residency in 2015. I did vascular fellowship under guidance of Professor Yoko Kato. I did fellowship in spine in UK. I did fellowship in minimally invasive spine surgery with Professor Mehmet Zelili in Turkey. So I'm working in this hospital. It's a 1,200-bedded multi-specialty hospital. This hospital is well reputed in Asian continent, it being the #1 gastro center, and they have expanded their wings in other branches as well. So our neurosciences unit has 50 beds with 10 beds of ICU and 2 beds and two functioning operative theaters. And this is our team. We have subspecialized in such a way that we cover all the spectrum of neurosurgical elements. And these were some of my pictures in 2016 when I visited Japan with stalwarts here. And this is one of my favorite picture with my mentor, Professor Kato madam. So I still use this arachnoid scissors for dissecting the sylvian fissure for aneurysm surgeries. And we had an opportunity to felicitate her in 2019 when she was in Hyderabad. And he's my mentor in spine, Professor Mehmet Zelili. So today's talk would be a brief about the history, the workflow of the navigation, the technical glitches, the problems, what we faced during the initial days. We have been doing it since 2021, and we have almost completed around 400 odd screws placements. And I can proudly say that this is one of the highest in our both states, that is Telugu speaking states of South India. And followed by a brief discussion and conclusion. So the first transpedicular screws were placed by Harrington and Toulouse, and thanks to this legends who have taught us the different trajectories of transpedicular screws. We often keep hearing from our kith and kin that all the spine surgeries have got poor outcomes. It is associated with a lot of morbidities, leading to deformities like paraplegia, paraparesis, and prolonged immobilization, that is bedridden, and long incisions. But the truth is that with the advent of the technique and technology, the modern day spine surgery has been with very extraordinary outcomes and early ambulation. Most of the times we are doing small surgeries like endoscopic disc surgeries and microscopic disc surgeries as a daycare procedure, preventing the morbidities, and it has been minimally invasive. This is one of my favorite slides with regards to the evolution of spine surgery. The imageology has taken a great part. That is, initially we used to use X-rays, later followed by 2D C-arms, that is 2D fluoroscopy, a 2D digital fluoroscopy, 3D fluoroscopies, then first generation navigation system, CT guided navigation system, or finally the robotics. So what all we need for this navigation? In our institute, we have this. We have O2, the OM manufactured by Medtronic, Still Station S8. And what we need are the rigid frame fixations, the navigated passive planar, the navigated Jamshidi needle, the navigated awl, the navigated tap, and the navigated screwdriver. So the steps of navigation are, first we need to make sure that the fixation is rigid. We can use a frame, array, or a percutaneous pin in the iliac region. Get the O-arm, take a spin, acquire the images, registration, and calibrate the instruments. So I'm going to play a brief video. So we make sure that the reference frame is rigidly fixed to the spinous process, and we then park the O-arm. After parking the O-arm, we take the 2D images, that is the true AP and true lateral. And after taking the true AP and true lateral views, we run a 3D spin, that is a low dose spin. And once the images are acquired, we transfer it to the navigation system. Later, we need to calibrate the instruments properly. And the catch here is we need to check it very often with the reference frame and with the bony prominences. And then with the passive planar blunt, we mark the trajectory. We see what is the trajectory, what is the length of the pedicle, what is the length of the screw, and then we tap it with the Jamshidi. Another catch here is, while placing the guide wire, one needs to be very careful, because it so happened with one of our case that in particular in osteoporotic spine cases, these guide wire gets displaced anteriorly. So after this, we need to do a serial sequential dilatations for the giving way for the screw and separating the soft tissue. Later, under the navigated tap, under navigation, we tap the screw, and we need to make sure this assistant is stabilizing the guide wire, and we basically have a real-time image there. And once it is done, then we need to go to the opposite side, and these 4 screws are placed. So this is how it goes. First is the placing of the reference frame, acquiring the intraoperative CT, navigate the instruments. So what we do is we contralaterally place the pedicle screws first. Ipsilaterally, we tap it and we keep a guide wire in situ, and we come out. We lateral create, we're not going to open the midline, sparing the multifidus muscle. We connect both the incisions, and using a tubular retractor system, we do the decompression, discectomy, followed by interbody fusion. Later, we remove that, we place the ipsilateral pedicles, and finally, the rod fixation is done. And once we finish, we see how the construct is like. So we get it, we again get the O-arm, and we use a low dose spin here to find out what is the position of the screws and what is the position of the cage which we have inserted. So here I'm going to play some of the cases. This was a child of 12 years old. He had a history of trauma while playing in the school, and he came with right upper limb monoplegia. And in the CT, we could see that there was atlantoaxial dislocation with rotatory component. It was not easy. So we used a O-arm in this case. We could find the trajectory. We would able to measure the length of the pedicle, width of the pedicle, length of the lateral mass, width of the lateral mass, and safely, very safely, we could place the pedicle screws in C2 and lateral mass screws in C1. And this was the patient's post-op picture where we can see where he came for the first visit, and gradually his power also improved. This is another case of severe traumatic brain injury due to road traffic accident. The patient had EDH, SDH, diffuse brain edema. He had type 2 odontoid fracture. He had splenic laceration. He had globe injury. And so as a routine, we get all the imageology done. And we could see that there was odontoid fracture type 2, and we presumed that to be a stable fracture. We kept him on Philadelphia collar, and it took a lot of time for him to improve because it was a stormy post-operative outcome. And after 3 months, he was shifted to a rehab center. And one day we got a call saying that the patient had quadriparesis. And to our surprise, when we repeated MRI, we could see that there was a displaced. So it was an unstable fracture. And again, with OARM guidance, we did this beautiful C1, C2 fixation. And gradually the patient's deficits also improved. And theoretically, whether we have placed these screws accurately or not is classified by Gebstein and Robinson's classification. A and B still are acceptable. C, D, E are not acceptable. That is, even if you have a breach, maybe around 2 mm in the lumbar screws or the dorsal screws, medially or laterally, is still okay. But C, D, E are not accepted, and we need to remove the screws and we need to replace the screws. And coming to the literature, what does the literature say? There are several studies on this. This is one of the meta-analysis study, where they compared C-arm fluoroscopy placements of pedicle screws with the navigation, and they found that the accuracy was high. That is, it is 95.2% in pedicle screws under navigation, whereas under C-arm navigation it was 90.3%. This was a study done in South India, in Ganga, Coimbatore. This, in the case of deformity surgeries, that is in thoracic spine surgeries, Professor Rajshekharan has compared the breach in the group. In group where they used the C-arm, they found 23%, and in navigation group, they found the breach to be only 2%. This is another meta-analysis where they compared the C-arm with second generation CT-based navigation versus O-arm, and totally they found, the total screws were around 7,533, and the O-arm navigation screw were more accurate when compared to CT navigation and to C-arm. There are some other studies which again differ, which differ with the O-arm group. So in this study, where they have done cervical, lumbar, and thoracic pedicle screws with freehand technique and O-arm, they found that the pedicle breach was almost same. That is 12.6% in the freehand technique and 20.1% in the O-arm. There's another study which emphasized on the operative time and also the positioning of the O-arm and positioning of the patient and acquiring the images. And they found that the O-arm group patients who underwent transpedicular fixation took much more time compared to that of freehand technique or using C-arm. So this was study done in All India Institute of Medical Sciences in the trauma unit, and they found that when compared with C-arm and O-arm, in trauma patients, the transpedicular screw placement under O-arm was far superior when compared to that of C-arm group. So in our experience, in our personal experience, since 4 years, we operated on total 74 patients, total of around 296, around 300 screws, with dorsal being 48, lumbar 218, sacral 14, cervical pedicles around 8, and C1 around 8. Average time, initial days, we used to take a lot of time to park the O-arm, but as the time progressed, as the cases progressed, we started doing it fast, and average time to park O-arm is 6 minutes, and to drape the O-arm, it took around 4 minutes. And initially, it used to take a lot of time, but later, once we have become familiar with these procedures, we took almost 8 minutes on average to place each screw. So this was the initial days. The patient herself was a doctor. And as you can see, there is a severe osteoporotic fractures. And this was one of our failures case, rather, I can say, because we placed this L4, L5 screws, okay. But when we were placing it on particularly on the left side, L5, we could found that there was the guide wire was misplaced, but still we couldn't recalibrate the navigated screwdriver, and we placed it like that only. And we got a X-ray done, and so it was like this. It was the screw was it was placed into the it was not into the vertebral body. So we removed it again and we placed. Of course, luckily the patient didn't had any deficits. So there were some cases of surgical site infection because of prolonged surgeries, with cultures being negative and which were addressed with linezolid. And lateral pedicular breach was seen in 19 cases. Of course, there were A and B, and even in the medial breach, it was A and B. Of course, I've showed you one of the picture of mal-aligned screw where we were forced to come back, remove it, and again place it properly. This is how our journey started, and this is one of the cases which we did recently. So for everything, there is pros and cons, and there are advantages and disadvantages. The advantage of using O-arm is definitely it has got decreased radiation exposure to the surgeon. The accuracy is very high when compared to C-arm, and the decreased radiation exposure to patient with regards to MISS. The MISS, we take multiple shoots. That
I think this the voice and message comes across to audience. Maybe it's a connection problem. Maybe shall Professor Sharma, shall we wait for a few minutes and I'll email.
Yeah, we can just wait for a minute and see.
Yeah, and if not, then we can proceed to our next.
So, Karen, you want to say something?
Oh,
Then
yes.
is
Yeah.
he back?
Yeah, he's back. I'm making him as the host again.
Okay, good.
Hello, Dr. Sakan. Can you hear us? Hello, Dr. Sakan. Can you hear us?
He's here, but I suppose.
Sorry, maybe can we proceed?
Okay. I think let's move on here.
Yeah.
And then he can always finish
Yes.
once he's back.
Yes, I think so,
Then is that
yes.
okay?
Yeah, no problem. Please.
Okay.
Professor Chen Xiaolei, so because of the technical problem, can we start the session? Is that okay?
Sure, no problem. So, dear Chairman, dear Professor Kato, and dear colleague, today it is truly my honor to be here and share with you our experiences. Let me share my screen. Share our experiences for the virtual reality, augmented reality, and the mixed reality. I'm Dr. Chen from Beijing, China. So first, please allow me to briefly introduce the concept of the technology that we will describe today. First is VR, which is quite familiar to all the people in nowadays. It means virtual reality. The objects displayed in a virtual reality mode, they are all virtual, generated by the computer. So there's no real thing in the scenario of the virtual reality. And the second concept is augmented reality, also known as AR. It means virtual objects generated by the computer was injected or projected into the real world, make it the AR display. The latest concept is mixed reality. It means holographic objects generated by the computer plus the real world. The hologram was projected onto the real world scenario, and as well as virtual manipulation. So this is a picture of the VR, which is very familiar to all the people. And for medical use, we use a VR to simulate for example, in this case, simulates the neurovascular confliction. The technical details will be described later. And for AR, for daily use, there's a mobile phone game, which is known as Pokemon Go, which is quite popular in Asia or even around the world. But for medical use, we use AR to help us to localize and for the surgical planning or for the surgical intervention. For example, in this case, we generated the three-dimensional model of lateral ventricles as well as trajectory for this catheter insertion for EVD. So we projected this three-dimensional image onto the patient's head, which made it augmented reality display. In this case, it augmented our visual capability. So now we can see through the skull of the patient and see directly to for the image of the lateral ventricles as well as trajectories. For mixed reality, we will have a more step forward. The operator, the neurosurgeons, can wear this kind of a mixed reality helmet or glasses. And then in this case, this patient is suffering from trigeminal neuralgia. We can generate the brainstem, the basilar artery system, as well as trigeminal nerve on both sides and make it a hologram. So this hologram can be projected, or we like the floating in the real world. And we can use a gesture to do the virtual manipulation of the hologram. This will be very suitable for the neurosurgical operative situation. So first, let's talk about the VR simulation for surgical planning, for neurosurgical planning. This is a typical case, 1-year-old female. If you consider or observe only check the CT image, the diagnosis of a hydrocephalus can be easily done, but the appearance can be deceiving. The patient got shunt in another institute, and 1 month later, the hydrocephalus is still there. The hydrocephalus didn't get any relief. So what happened? If we check the patient with a 3D space sequence MRI with superfine resolution with a slice thickness of 0.6 millimeter, you can see there's a cystic lesion arising from the prepontine cistern and blocking the foramen of Monro on both sides. But how can we lower down the difficulty level to make more people, to make young neurosurgeon with less experience to do the correct diagnosis? We can use VR simulation. So let's see the VR image. So this is a VR image we generated with open source software. Everybody can install this software free on both Windows system or the Mac system. So from this view, you can see now we are looking from the top of the patient's head, and now we can simulate the endoscopic procedure. We fly now into the right lateral ventricle of the patient. So now we can see clearly, here's the foramen of Monro, and there's a membrane blocking the foramen of Monro on the right side. But if we check the left side, we can also see a membrane-like structure blocking the foramen of Monro. So from the middle, we can see there's a balloon. Actually, there's a balloon in the third ventricle, which blocks the foramen of Monro on both sides. And in this stage, we can easily make the diagnosis. This patient is suffering from a suprasellar arachnoid cyst. And if we fly through the cyst, into the cyst, you can see very interesting structure. This is a trunk of the basilar artery, and this is a bifurcation of the basilar artery. This is PCA on the left side, the PCOM on the left side, and the ICA on the left side. And on the right side, you can see the right side ICA here, right side PCOM, and right side PCA. So in this way, we can see almost all the whole Willis article circle here. So we back to this patient, and once we made the diagnosis of a suprasellar arachnoid cyst, then an endoscopic fenestration will be the first line treatment method for this patient. And so that's what we see intraoperatively. You can see the foramen of Monro was blocked by a cyst. And if we open the cyst to perform the fenestration, we come into the cyst, we will see the scene is almost identical to the virtual reality simulation before the surgery, right? The bifurcation of the basilar artery, the PCA on right side, PCA left side, PCOM left side, as well as pituitary stalk and pituitary. So in this way, we successfully simulated the scene in the ventricle, in both lateral ventricle and the third ventricle. In this way, we call it the virtual endoscopic procedure. Okay, now after this kind of, we call the single model VR simulation, we can also do the multimodal VR simulation or planning. For example, in the case of this 65-year-old male suffering from the hemifacial spasm for 20 years, and if we perform the conventional MR imaging, the information provided to us is very limited, it is quite difficult to do the correct diagnosis and to find the offending vessel. But if we perform the multimodal VR simulation, it is almost no sweat. It's a piece of cake for us to do the simulation and find the offending vessel, which is in this case AIC here. So we can also rotate the virtual reality objects to align the surgical procedure approach. So in this case, we can see the offending vessel AIC has a big loop and compress on the REZ zone of the facial nerve. So can we also perform a more vivid and interactive way for this kind of case? Yes, we can. So we can also use a kind of a interactive model to simulate the patient situation here. For example, this case. So we can easily rotate the model and simulate the surgical approach, which in this case is a kind of occipital approach, right? That's a typical and a classic approach for this decompression in the case of hemifacial specimen. So in this case, we can also easily make certain that the offending vessel, there's only one offending vessel from AICA. And in this case, the supracerebellar artery here is, there's no relationship between this artery and the facial nerve. So in this case, we just go directly into the, directly for the offending vessel, perform the decompression, and without the 360-degree search for another offending vessel, which will save us a lot of time and makes this operation less risky. So, and intraoperatively, the VR model can be imported into the computer, and we can use this kind of a touchless manipulation to do the manipulation with virtual reality model, so that we can observe and we can check the offending vessel very much in detail intraoperatively. So intraoperatively, the intraoperative microscopic view confines very much in detail, very good with virtual reality simulation. You can see the artery loop here from the AICA. So the decompression was successfully done, and there's no complications after the surgery. The patient, this is a video of 1 week after the surgery. The patient's hemifacial specimen has already completely relieved. And so far, the patient was followed up for more than 6 years, and nothing. There's no recurrence of this situation. So after the virtual reality, we make one step forward. So we want to integrate these virtual reality objects for low-cost AR navigation or AR planning system. So this is a 60-year-old female suffering from a big lesion, most probably the meningioma, located in the frontal lobe. And we made this vitamin E capsule adhered to the patient's scalp, which the vitamin capsule is extremely cheap. So we performed the 3D modeling virtual reality simulation first, as well as the vitamin E capsule as markers and the tumor. And intraoperatively, we could just simply project the image onto the patient's skull, and to coincide the virtual markers to the real-world vitamin E capsule. And in this way, the tumor was directly projected onto the patient's head. In this way, this technology enhanced our visual, make us to see through the scalp and to see the location of the tumor directly. So in this way, we can easily make the plan here, right? So later on, we also developed the AR with a mobile device. We use simply an iPhone to manipulate the virtual reality objects until they coincide to the right position on the patient's head, right? So for some case when the accuracy level was not so high, you can easily directly use the iPhone camera to do the iPhone-based AR. We published this technology in 2016. So basically, you will got image like this on the iPhone screen to do the AR localization of the hematoma here. For Android users, we also developed this kind of Android-based AR technology to do the hematoma localization here. We published this on the Journal of Neurosurgery in 2017. If you are interested, you can check the technology details there. So our latest project is a mixed reality simulation for planning. So in this case, neurosurgeons wear a mixed reality helmet or mixed reality glasses to do the intraoperative planning and localization of the objects. For example, in this case, this is a meningioma, small meningioma. We can first use virtual reality to do the 3D modeling of the tumor, the sagittal sinus, and the markers. And then we use mixed reality to do the real-world localization of the tumor on the patient's head. So in this case, you see the hologram of the tumor as well as the sagittal sinus and the markers are projected onto the patient's head. So in this way, you can easily perform the surgical planning and the navigation for the patient. So for the semi-automatic registration, mixed reality navigation, we performed this project. So first, we perform the virtual reality simulation with the open source software 3D slicer. With this case, you see, these are all virtual. These are virtual reality simulation. And then we perform the semi-automatic registration in a mixed reality mode. Now, with this 3D printed positioning tool, we can easily make the registration for the navigation system. You see, we just need to register 5 markers, and then we can get a mixed reality object projection onto the patient's head. So 1, 2, now it's a third marker. All the manipulation are made by the gesture manipulation, so which is very, very easy and straightforward. So after 5 markers registration, you can see the green tumor, which resembles the tumor, was the hologram was directly projected onto the patient's head, as well as sagittal sinus. Then we will measure the distance error for this technology and compare it to the standard neural navigation. So this is our latest project with a markerless mixed reality navigation. So you see, we no longer need to adhere markers onto the patient's head. We can just scan the face and then perform the automatic or semi-automatic registration of the hologram. So now in this case, this is a parasagittal meningioma. We can also has the hologram of the meningioma as well as the sagittal sinus projected onto the right place of the patient's head. So for this project, for mixed reality navigation project, we totally enrolled 37 cases into the study, and the median error of our technology is 4.1 millimeter. If we compare to a standard neural navigation system, the median distance error of the neural navigation system is 2.5 millimeter. So our distance error is acceptable for some not so delicate or not so precise procedure. For example, the big lesion resection or the hematoma evacuation. So we published this paper in Neurosurgical Focus. If you are interested, you can check the detail there. This is another branch of our mixed reality project, which is internet-based planning and training system. So now let's see a short video clip for this system. First, we wear the mixed reality helmet and start the mixed reality app generated by us, programmed by us. So we scan the positioning board, and we have a very dazzling starting image, and from this the bone of Adam. And now the patient's hologram. This patient is just the hemifacial specimen case which we demonstrated before. We now use his hologram to demonstrate and for the surgical planning. So now we can invite the trainee to participate into our online planning room. So in this case, the trainee is using an iPad to enter the training room. Now, so this is an iPad screen. So the trainee will scan the positioning board, and then he will see the same hologram of the patient with a trainer. So all the manipulation we can for the trainer, we can move, we can rotate, we can mark on the hologram. All the manipulation made by the trainer, either the trainer or the trainee, can be updated onto this hologram and transferred through internet, and so that the trainee can or the trainer can see the updates at the same time. So we tested this system and planning system and training system for several locations. The longest distance, the farthest location is from the Erlangen, Germany, or the New York in United States to Beijing. So our system can host 13 trainees, 12 trainees with one trainer, or totally 13 users at the same time online. And so the delay is within 300 milliseconds, which is acceptable for a planning and training system. So now, once we once the trainer can perform can add the marker or can fade the objects, and through the vocal instruction can train or teach the trainee for the details of the surgery. And we can also, the trainer can also add markers for the trainee, for example, to tell them which one is a offending vessel, which direction he should go for surgical procedure. And we even has English and Chinese selection for this. So now we can see there are 3 users in the training room. 2 users are trainee. Now the trainer has passed the manipulation right to the trainee. So now here's a trainee scene. A trainee can also wear a holographic, a mixed reality helmet, or use an iPhone or use an iPad to do the manipulation interactively with patient's hologram. So now in this case, the trainee is using the iPad. And the trainee can also perform the mark, can do the mark on the hologram, and to do the interactive either the discussion or the other comment with the trainer. So this is a true internet-based mixed reality online training system, and the cost is quite low. Actually, the hardware cost is within 10,000 yuan, which is less than maybe 12,000 US dollars or something. Anyway, and the cost is quite low. So here's our results of our online training mixed reality training system. I do not have time to discuss it in detail. If you are interested, you can check our paper, which was published on the neurosurgical focus. After that, we still wanna keep the ball rolling. So we wanna simplify the workflow. We wanna have develop a low-weighted MR device, mixed reality device, and we wanna further lower down the cost of the device. So here's a result. We developed this kind of newly light-weighted mixed reality helmet. And I personally has already test drive this device in Xinjiang, which is in Xinjiang, China, which is still quite underdeveloped country, not country, the part in China. So we have separated parts design with standard Android devices, which you can put it into your pocket. And in this case, it is decreased the weight of the system, and half of the weight of the HoloLens 1, and it's completely made in China. And we want to lower down the price to about half of the HoloLens. So summary, from VR to mixed reality, it is technically feasible for real-time local and remote online planning, training, or intraoperative navigation. So with our mixed reality and or the virtual reality training system. And it can effectively help neurosurgeons in patient-specific training for neurovascular confliction and intracranial tumor cases and all the other cases, for example, intracranial hematoma cases. It is easy to use and the cost is quite low. And our system may have broader application prospects in neurosurgery in the future. So the last picture shows our surgical building of our hospital. Our team has more fancy and interesting projects going on in our hospital. You guys are welcome to visit us in Beijing in the future. Thank you very much.
Thank you so much, Professor Xin-Xiaolei. Thank you so much for your presentation. Shall I invite comments from our chair, Professor Sherman?
Again, a brilliant talk, Chen. I think what you guys are achieving is commendable. There's been a lot of advancement in different types of lightweighted HoloLenses, etc. But I haven't seen anything like this before, and to bring it so cheap is amazing. Tell me, in your real-time clinical experience, in what way do you think it's different to what you were using with high-tech HoloLens technology? In what way is it different? And do you think you're giving the same results, or do you think it's different?
Well, That's a great question. Thank you for asking. Usually, my team and our institution is almost the first pioneer to do the multimodal neural navigation in China. But so many years after we use the navigation, we found the problem with the standard navigation, which can be overcome with the mixed reality technology. The thing is, first, the standard navigation has a loss of sight, which is if there's something block between the camera and the reflection balls, then the navigation will not work. But with mixed reality navigation, we use this helmet. Actually, this is navigation itself. It's untethered. So it doesn't matter if people walking around the operation table. As long as there's no block from my helmet to the patient, we can do the navigation, right? The second thing is we call it the attention distraction. For example, when we use the navigation system, usually we will looking other direction for the navigation screen. So the patient head is still here, but we are looking on the wrong direction for the navigation screen. That's not good for our workflow. So with this mixed reality navigation, we are looking at the same direction onto the patient head, as well as the navigation objects there. So in this way, we can become more focused and avoid some human error, right? The third thing is the cost. The navigation system is very expensive for China, this kind of underdeveloped country, right, or developing country. So the mixed reality navigation is lightweighted and low cost. So we think the mixed reality from this aspects can have clinical impact to our daily clinical practice. Thank you.
What about the pitfalls? What about the problems that you face? Like, any new system you start to use, there are always issues. So what are the problems you are facing, and how are you thinking of solving those challenges?
Yes, that's another great question. So now the first pitfall, the first issue is precision, the navigation precision. As I have reported, the medium distance error is 4.1 millimeter, which is still not as good as a standard commercial available neural navigation system. So we are working very hard to improve it. So for the distance error, for the navigation error. The second thing is weight. So it's a little bit heavy if you wear it for 3 or 4 hours. So that's a problem. So that's why we are improving to make it a separate design to make it lightweighted. The third thing is the battery time. So now for HoloLens 1, we can wear it. The battery can hold for 3 hours. But for a long session, it cannot hold such a long session, right? You can also connect one power bank with this HoloLens. It's possible. I guarantee you, it's technically possible. It can extend operating time for a long time. But the neurosurgeon the head will be very exhausted after 3 or 4 hours. So that's a problem that we are facing it, and we are working on it. Thank you.
Yeah, can I ask a question, Professor?
Please.
Yes. First of all, thank you very much, and congratulate to your success. I haven't seen the application that can develop so far in your hospital. Usually, in what cases would you use this technology? Would you apply it in all cases that you navigate? And so what are the pathology that you want to use? My second question is about can this technology be applied to vascular surgery? For example, can the VR can stimulate the flow, giving you the animation of the blood flow? I think this can be useful when planning the surgery. So my third question is about for the development that you have the lightweight gadget, and is that developed by a local Chinese company, or is it available in the market? Or?
Yes. Again, great questions. Thank you for asking. For the indications to use this technology, I think it is very, very, very broad. For example, for virtual reality simulation, my team is now using this virtual reality simulation for almost all the hydrocephalus case to do the virtual endoscopic simulation, and for all the neurovascular confliction, which is mainly the trigeminal neuralgia and the hemifacial spasm, to check the offending vessel, very effective. And for the brain tumor, especially the glioma, to simulate, we can also perform the skull strips, which means the simulates the cerebral hemisphere as well as a tumor. So in this case, you can easily localize the tumor. And for mixed reality, since it's a little bit complicated, because the distance error is still quite big, so we are now use this for the following indications. For example, the bedside EVD, external ventricular drainage, catheter insertion, the superficial meningioma localization, and the incision design. And the third will be the hematoma evacuation or hematoma catheter insertion, because the hematoma is usually quite big when they need the surgical intervention. So the precision level is quite low. I mean, the precision level is not so high. Obviously, you cannot use this technology for DBS, so electrode implant, never, right? So that's indication. What is the second question?
Blood flow stimulation. Can it be done in the planning with the VR?
What stimulation? Blood flow?
The blood flow, the vascular.
Yes. We do have experiences for this. For vascular disease, you can use this as well with together with CTA or MRA to simulate the aneurysm or AVM. We have a very nice case which we performed in Xinjiang in a county hospital, which is a very rural part of China, with limited resources. They do not have DSA. So we use CTA as well as a virtual reality simulation, and to check the nidus and the feeding vessel, feeding artery. And then after the craniotomy, we directly go to the position of the feeding artery. In that case, we have 4 arteries. We control the 4 arteries first and left the drainage vein patent until the last minute for the resection of the AVM. And we successfully performed that case. So if you are interested, we can show you the nice picture of that case for the AVM, for a giant AVM. So my opinion is for neurovascular, cerebrovascular diseases, we still can use this virtual reality or the mixed reality navigation for the to localize the feeding artery and to localize the aneurysm itself. So it's possible and completely technical feasible. So the final question, the helmet.
Yeah.
Yes, it's commercially available. We developed this, and now a Chinese company is it's completely made in China, and a Chinese company is selling this helmet. We're still making some modification and improvement for this mixed reality to make it has more versatile function to do the job, including the navigation, the preoperative planning, and the multi holographic virtual panel display intraoperatively. For example, now we can achieve this. You have intraoperatively, you wear this helmet, you see 3 virtual display panel here. One is from the monitor, including the heart rate, the blood pressure, etc. One is from the intraoperative electrophysiology monitor. You can see when you do the direct cortical stimulation. In the center, there's a picture from an exoscope or an endoscope or microscope. So in this way, you have a multi-screen, versatile, multifunction, holographic, mixed reality display system here. So in this case, it's completely technical feasible. So if you want to buy, if you want to, so that because we are not selling products here, right? So you can contact me, and I can introduce you to the Chinese company. Thank you.
Thank you so much. There are also 2 questions in the chat box. So the first question is about, as in your presentation, your device could potentially replace the navigation. Is there any study to compare the accuracy between the HoloLens system and also the traditional navigation system? And the second question is, can this virtual reality device integrate into the microscopes?
Okay, great questions. First question, I have already answered in my presentation. We published this controlled study, which is comparing between our mixed reality navigation system and the standard BrainLab standard neural navigation system. We published this paper, this study, in 2 years ago in Neurosurgical Focus. You can check it. If you are interested, you can also contact me. I can send you the paper and as well as the results of the study. The second question, I should say, it's opposite, that we can integrate the microscopic view into our mixed reality system, which can make you see a virtual display panel with a microscopic view floating in front of you in the air. You can drag this panel anyway, any place that you want, and you can also zoom in and zoom out with this. So if you are interested, maybe I can show you later also on this webinar with our latest project. Thank you.
Sure. So maybe any comments from Professor Aniku? Any comments from you after hearing this? Yeah, please unmute yourself.
Yeah, thank you so much, Dr. Ben. Yeah, thank you, Professor Chen, for this presentation.
You're welcome.
Virtual reality, this technology is, we cannot find it around here. We read it in textbooks. And it's great hearing from you. Thank you so much. I so much appreciate. Thank you, sir. Yeah.
You're welcome.
Then if I could ask you, and how is it possible to do it the other way around? Because you're putting something heavy on your head and it's where you're looking. So why can't you put all this in the microscope so that, we are looking in the microscope and steady thing is right in front of you and you're not taking something on your head.
You mean
Put
it's a
all this in the
microscopic?
microscope. Yeah, so you put everything in the microscope, so it's not on your head, and you just do what you want to do, and you can click and change whatever you want to see in the microscope.
Yes, that's a great idea, but so far we haven't achieved this. So as I have already reported, the things is opposite.
Right.
So because for holographic, for mixed reality navigation or display, it is quite interesting that when you walk around the patients, the objects, the hologram is like just floating inside the patient's head. And you can never achieve this with a microscope, right? You can rotate the microscope, but you always see the view from only one direction. So it's I mean it's two sides of the story. So usually we use a mixed reality device to do the initial localization of the lesion of the tumor or hematoma and design the incision, and then we take off the mixed reality device and we perform the surgery. So that's why I say the indication mainly now is superficial, like meningioma or superficial glioma, because in that case, once you make the localization and make the incision, the tumor is there. For any deep-seated tumor, it's not suitable. For small lesion, it's not suitable. So that's a reason. So, but your idea is very interesting. We were working on it. We were all working on it. Thank you.
Good.
So, are there any questions from the floor? So, if not, Professor Sherman, shall we, since Dr. 𝐸𝑒𝑒𝑟𝒑 is here, shall we let him to have a few comments on for him?
Sure.
Yes, sir. I'm ready to take the questions, sir.
Yeah. So, Dr. 𝐸𝑒𝑟𝒑, do you have some final some remarks for your presentations, since there are some technical problems?
Yeah. In fact, Ben, that was the last slide where I have emphasized upon the advantages and disadvantages of having an OARM. And finally, we need to have a proper, well-planned surgical anatomy in our mind, the surgical anatomy and orientation of pedicles in our mind before whatever procedure you use a C-arm, you use a freehand technique, or use a OARM. That is, still they say, there is a saying that a tool in the hand of a fool is still a tool. So it is the anatomy, the 3D anatomy, which we have to have before going into the surgery. So if you have OARM, that's well and good. But if not, the basic thing what I wanted to emphasize is we have to have the proper 3D anatomy before placing the pedicle screw.
Totally agree.
I see. Thank you. Thank you so much. So, are there any comments from or some final remarks from Professor Kato?
Thank you so much. So the three talks were very excellent. Already Dr. Kim has left. Thank you very much, Dr. Chen. So I think a very, very ideal, and maybe the future some good device, I think. But especially for us, maybe a bit deeper seated capilloma or small lesion, and also the glioma is, I think, most helpful with these devices, I think. And also the Dr. Salman, he mentioned that maybe it's very heavy devices is maybe in the microscope in the future, I think. Thank you very much, Dr. 𝐸𝑒𝑟𝒑, and thank you very much for your nice presentation. Unfortunately, we are so sorry about your the connection is not so nice, but I think we understand well what you are doing. So
thank you.
Maybe that, yeah, for the best in your future career. Thank you so much.
So, so if there are any no further comments, so shall I close the section, Professor Kato? So,
yes, of course. Yes.
Okay, so on behalf of the Education Committee of the ACNS and the President of Professor 𝑚𝑒𝑟𝒃, I would like to thank the Chairman, Professor Salmon, and also the speakers, Dr. Yun Sung Kim, and also Dr. 𝐸𝑒𝑒𝑘𝑒𝑟𝒔, and also Professor Chen Xiaolei for their excellent presentations, and for the time and the support for the ACNS webinars. And also a special thanks to Professor Xu Bin for broadcasting this webinar on WeChat channel. Today we have more than 400 viewers on the WeChat channel, and a special thanks to my co-host Professor Alia Koo, and also Dr. Biswas, who was here for joining me today. So so until we meet online next time. So it's bye-bye for all of us. And thank you so much for all of you for joining. And thank you so much. And stay tuned to the ACNS activities. So thank you so much for all of you.
Oh, Dr. Kim, thank you so much.
Oh, Kim,
Yes,
hello.
please.
Excuse me. Excuse me.
Please.
I wanna tell you. Excuse me. I wanna tell you that this program was just live in a major neurosurgical media in China. So we have over 4,000 audience here checked our and watched our program. So you should know that this program and this webinar has a very deep impact in China, because in China totally we have 12,000 registered neurosurgeons, and today we have over 4,000 audience.
Okay,
so that's a great
Thanks,
achievement.
Okay, we work together. Thanks so much. Okay, so the someone maybe you can send me about the member. Okay?
Sure, definitely.
Thank you. To see you next time.
Yeah,
and also thank you, Professor Kim.
Thank you, everybody. Bye-bye.
See you.
Thank you, Chen.
Bye. See you next time. Bye-bye.
Bye.
Second, all the best.
Thank you, ma'am. Thank you.